All right. Well, welcome everybody to the last main stage session for today. My name is Lindsay Booker, and I'm co-moderating this session with Ryan Cruz and Robbie Bowers, and we are very excited to welcome you here this evening, and we're also really excited for you to hear from our awesome speakers. We're going to go ahead and introduce everyone that will be speaking in this panel, and then we'll have about 10 to 15 minutes at the end for Q&A, and so we just ask you and invite you to put your questions into the event Mobi, and we'll try to get to them at that time. So our first speaker will be Dr. Gary Ho. Dr. Ho is a fellow of AMSSM, ACSM, AAFP. He is a board-certified family medicine and sports medicine physician. He holds additional credentialing in musculoskeletal ultrasound, point-of-care ultrasound, and the management of concussions and other traumatic brain injury. Dr. Ho actively serves on the standard-setting committees for sports medicine board certification, ultrasound certification, and ultrasound practice accreditation. He also teaches internationally. His special interests include musculoskeletal and neuromuscular ultrasound, peripheral neuropathies, running medicine, martial arts, combative sports, orthobiologic therapies, among many others. Dr. Ho is a current team physician at George Mason University, and he serves his community as a sports medicine physician at Ortho Virginia in the Washington, D.C. metro area. So without further ado, I'll welcome Dr. Gary Ho to the stage.
Thanks a lot, Lindsay, and really appreciate the forum. And without further ado, I'll just jump right in. All right, so let's see here. No relevant financial disclosures. So what I'm going to do is provide a brief review of the role of diagnostic imaging in the assessment of peripheral neuropathies in clinical sports medicine. We'll compare and contrast two of the arguably most useful diagnostic imaging modalities for peripheral neuropathies, and that's MR, neurography, and ultrasound, and then wrap up with some considerations for the practicing sports medicine clinician to hold when it comes to choosing the best diagnostic strategy for the assessment of our patients. So peripheral neuropathy is something that relatively common in what we encounter. It seems to be increasingly common in what we see in the clinic. They can be quite debilitating for our patients. So it behooves us to be mindful about our diagnostic and assessment strategy. While what I'm talking about today is going to be widely applicable for multiple different subtypes and mechanisms of peripheral neuropathy, a lot of this is going to be most immediately apparently applicable for our mechanical peripheral neuropathies, such as entrapment neuropathy. These conditions are diagnostically complex. No one clue set is perfect. That includes what we can obtain clinically from the history standpoint, from physical examination, and laboratory tests. And then also when it comes to electrodiagnostics and diagnostic imaging. So a word about electrodiagnostic imaging, and by that I mean EMGs and nerve conduction studies. They definitely have value, and we've been using them for years for the assessment of these conditions, but they have limitations. Their limited specificity and spatial resolution can make it difficult to really zero in to a specific topographic level or location. And that becomes important, when you need the neuroanatomic detail for guiding procedural treatments. Also, it's between 20 to 30% of peripheral neuropathy cases assessed with electrodiagnostics can either be indeterminate or otherwise unrevealing, and that can be troublesome when we're trying to target our therapy. So enter diagnostic imaging, which allows some complementary information to help perhaps give us a more complete picture of what's happening with peripheral neuropathies. Specifically, it allows us to do some topographic localization and look at the relationship of a particular lesion of a nerve with its surrounding environment. The extent of the injury can be assessed, morphological characteristics, and readily looking at associated end organ damage. It follows that diagnostic imaging can be helpful in informing our management decisions for pre-procedural planning as well as for post-procedural follow-up care. And of all the imaging modalities that are available, MRI-based MR neurography and diagnostic high-resolution ultrasound are likely the most diagnostic. Both are excellent imaging modalities. And with the continued evolution of the different technology and techniques for employing both of these modalities, which one is better tends to be kind of a moving target. But currently in 2026, how do they compare? Which imaging modality is best? And that's the question that I was asked to try to address today. So looking at the two types of imaging modalities side by side, you'll notice that there's a lot of overlap, but there's also some specific advantages and strengths that each diagnostic modality brings to the table. Looking at MR neurography, MR neurography enjoys high contrast resolution, a larger field of view, which can be particularly useful. It is also less operator dependent than high-resolution ultrasound, but however, there are still relevant considerations, especially when it comes to using particular protocols and certain techniques when it comes to MR neurography to get the most useful information possible. MR neurography is also less affected by certain patient factors, such as patient habitus, the nerve depth, as well as overlying gas and air. Compare and contrast that to high-resolution diagnostic ultrasound, where ultrasound enjoys higher spatial resolution, and then certainly the portability and availability, cost efficiency of ultrasound are aspects that are very important. For our patients, especially those with a history of claustrophobia, the excellent patient tolerance profile of ultrasound makes it very desirable. And then also the availability for diagnostic imaging and ready contralateral comparison. This is, of course, to be contrasted with newer, more updated MRN protocols to be able to look at structures in different body positions. So there are some advantages that can be shared between the two modalities. Ultrasound is also less affected by local metal artifacts, which can be important when we're looking at peripheral nerve lesions in close proximity to metal hardware, those who've had operative intervention for other problems. And obviously, ultrasound is going to be one of our imaging modalities of choice, especially for soft tissues, for the guidance of procedures. Both technologies have a set of biomarkers that have been shown good reliability when it comes to assessing certain findings to clue us into abnormalities. And from that, it also follows that both sets of technology include scoring and classification systems. But for the sake of time, we won't have time to go through that. So regarding the question of which one's better, this was addressed by Foss-Leitner et al. In a recent study this past year, where they took 800 patients with suspected upper extremity peripheral neuropathy, and all 800 underwent high-resolution ultrasound as well as MR neurography, read by 3 neuroradiologists. And then they looked at the accuracy, sensitivity, and specificity of both of these studies based on clinical examination, electrodiagnostics, and when available, surgical and histopathological correlation. And what they found was that MRN had higher accuracy and sensitivity compared to ultrasound. In addition, about 38% of the participants, there were findings that were thought to be clinically useful on MR neurography, which were not available on the high-resolution ultrasound. However, high-resolution ultrasound was found to be with higher specificity compared to the MRN. And what was really nice about the study is they did subgroup analysis to look at certain factors, patient and case factors, that might favor one over the other. And so MR neurography was favored in cases involving more proximal nerve lesions, conditions that involve multiple nerves in a particular region of the body, and those that had a longer length of nerve that was affected. While factors that favored high-resolution ultrasound included more distal nerve involvement, conditions that had multiple regions along the same nerve that were affected, and like I alluded to before, in certain cases where the nerve that was of interest was in close proximity to prior surgery. Ultimately, the authors concluded that MR neurography was more sensitive and accurate, while ultrasound was more specific. There are some limitations to this study, however. Single center cohort study, no blinding. Also, there were certain more novel approaches with ultrasound technology that were not used and included in the study, including elastography, superior microvascular imaging, and dynamic maneuvers. And when you compare that to other studies, the other studies have been more varied when it comes to their conclusion comparing MR neurography and ultrasound. So ultimately, though, I find that these two technologies tend to be complementary when available. And when there's, if you have them both available, I think they have blind spots that using both can actually cover each other and give us a more complete view of the patient's case. I think ultimately, though, when we ask the question of what the most important diagnostic tool that we have is, and that is the clinician's brain. You know, I think the clinical acumen, putting it all together. This little logo here, the Sherlock Homies, is actually the name of my clinical team that my athletic trainer coined, because he finds a lot of our activities as clinicians tend to follow along like a crime mystery detective. And like a good detective, you gather your clues from different sources and you cross-reference them to create a list of suspects, and then you interrogate those suspects. And I think this is where certain modalities such as diagnostic blocks and looking at the response to those can be very helpful to pare down an otherwise robust differential diagnosis. So with that, I'm out of time, and I look forward to the discussion that follows. Thank you.
All right. Well, that was outstanding. So thank you all for your time and your excellent presentation. So we do have about 8 minutes or so for some questions. So we'll get started here. So the first question is for Gary. So MR neurography is not ubiquitous. It's not present, at every institution. And so for those of us that have access to MR neurography, is there a specific protocol that you use that you've discussed with your radiology colleagues, or do you have any thoughts or recommendations on that?
Yeah, thanks for that question. If it's available, I think having a pointed discussion with your radiology colleagues to kind of nail down some specifics for their protocol would be helpful. In our area, which is in a suburb of Washington, D.C., we've got numerous radiology practices. And as I've talked to some of my colleagues on the radiology side, some of them will have slightly different tweaks to their protocol, also depending on their scanner as well. So having those discussions would be really helpful. The specific protocol depends on the condition that you're addressing. So for example, just to dovetail on that discussion about thoracic outlet syndrome, there are going to be specific protocols for TOS with the arm in certain positions and using certain sequences. But I think my main recommendation there would be to have those discussions with your radiology colleagues.
All right, so next question is for Ella. Given that a median nerve hyder dissection provides 4 to 6 months of relief, is there a limit to how many times you are repeating the procedure before you're going to recommend a carpal tunnel release?
That's a great question. I think the answer is very patient specific. Overall, there's very low, with any injection we do, there's always potential risks, right? There's a risk of penetrating that nerve. Obviously, that's why we're using ultrasound. There's risk of infection, et cetera. However, if the patient is really having persistent symptoms and they've had, say, 3+ injections and they're really not getting better, I think it's warranted to at least have that discussion with the surgeon to see if that's something that they want to pursue for more long-term symptom improvement. But from the actual literature, there's no hard answer one way or the other.
Great, thanks. All right, so next question is for Troy, or really for anybody, but we can start with Troy. So when you're doing nerve hydrodissections, do you have any idea how you're billing those?
Yeah, it's a great question. So it would be an ultrasound guided procedure code, so 76942, and then a nerve block is the only charge that you can drop. You need to be careful. So our group ran into this recently in the past 2 years where the coders and insurances were scrutinizing the notes, and if it said hydrodissection only, that was denied, right? And then we wouldn't find out for like years, right? And so we made a decision to make sure that the language in the note reflects the code for a nerve block. So you should at least say nerve block. If you want to say hydrodissection or something to that effect in addition, that's okay, but you still need to say that word block of some sort.
I'll chime in real brief there. We ran into that as well. And so our practice in our office is to quote, hydrodissecting block is what we use. Yeah, there is another code for neuroplasty, but that is really problematic when it came to a coverage standpoint. So that is not something that we've kind of switched away from billing that to third-party payers.
So next question can really be for anyone. And so this person asks, oftentimes my older patients who have a loss of terminal supination, and so the ulnar-based approach for a carpal tunnel injection or median nerve hydrodissection is challenging. And how do you approach these patients from an injection standpoint?
I'll take a stab at it. This is for anybody. So it sounds like the question is more about patient positioning and approach. And so I've gone to having them in a sideline position with the arm kind of next to their head like this, which allows you to access that ulnar side of the wrist with very little supination or pronation. Hopefully that's clear.
Yeah, I take a more simplified approach. I just do it in plane with the nerve. And I just inject a large volume and it seems to go around it, no problem.
You can also use the gel standoff to help give you more space.
All right, great. Well, I think we are at time. So again, thanks to all the speakers for the outstanding talks. Thanks to everybody for sticking around and listening to these great talks. And we will conclude there and enjoy the welcome reception.